want to welcome you all again today. I am Michelle Meltzer. I'm a rheumatologist at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania, and I'm here today to discuss gout. I chose this cartoon to open with because it shows the representation of gout that we had in the past. As you can see, the data is from the late 1700s, and it shows an obese, well-to-do man drinking what is probably either beer or some form of alcohol. So exactly what is gout? Gout is an abnormality in purine metabolism that results in an increase in the urate pool. And the results of this are acute attacks of gout, chronic gout, tophi, which are deposits of uric acid in the skin and granuloma formation, and then renal involvement. And this can be urolithiasis or kidney stones. So how do we get to the excess urate pool? Gout is caused by an excess of uric acid, which above a certain level of 6.8 milligrams per deciliter can precipitate out of solution. And about 90% of the individuals, sustained hyperuricemia is caused by impaired renal excretion. Recently, genes have been identified, urate transporter or urate1, which regulate serum uric acid levels and susceptibility to gout. Uric acid levels are higher in men and in postmenopausal women. But this slide demonstrates additional mechanisms for hyperuricemia. One factor is a decrease in renal excretion of uric acid, and this can be caused by renal disease and the use of diuretics. And this is particularly important as diuretics are being used more and more to treat hypertension. There are factors which cause a retention of urate, and one of the main causes of this is the use of alcohol, and there can be an increased reabsorption possibly caused by the lactic acidosis, which may be present with excess alcohol intake. On the right side of the slide, you see the liver. The liver metabolizes fructose, which is seen in sugar drinks and in some fruit drinks, into purine. So this is a cause of the endogenous formation of purines and is also becoming increasingly important. An additional factor is diet, and beer has purine. In addition, also has a carbohydrate which can be metabolized into purine, and meats and seafood are a source of purine, which is metabolized, as you can see in the next slide, to uric acid. And this is just a diagram to show you that the purines are broken down by xanthine oxidase to hypoxanthine, xanthine, and to uric acid. 90% of the uric acid is reabsorbed and then excreted in the kidney. As you know, febuxostat and allopurinol inhibit xanthine oxidase. Now, when looking for risk factors for gout, it's important to look at not only diet, but drugs that can affect the serum uric acid. And there's several drugs, including pyrazidamide, low levels of salicylate, diuretics, cyclosporin and tacrolimus, and ethambutol. Ethambutol and pyrazidamide, as you know, are two drugs which are used for tuberculosis. And I invite you to look in the reference, which will give you the mechanism of action of these drugs. And the next slide, I have drugs which decrease the serum uric acid. And it's interesting, you see salicylate, which is at high doses, is a uricosuric. Probenecid, of course, is a drug that we use to treat hyperuricemia. Losartan and amlodipine are both antihypertensives, and they can cause a small decrease in the level of uric acid, but usually alone are not enough to bring the serum uric acid down to target. And there's also the xanthine oxidase inhibitors, which I already mentioned, which is allopurinol and febuxostat. Now, or you've already seen me examine a patient with gout, but it's very important to see that gout can look in many different ways. So when we're making the diagnosis, one of the pitfalls I see, as you can see both of these slides, could certainly be cellulitis. And it is important to listen to the patient's story. Infection, of course, is in the acute, is in the differential diagnosis, but it's important to consider gout, especially on the hand. If you look to the right hand, not the left hand, you can see that there's a tophus on the index finger. And then you can see, again, there's another picture of a hand that's from gout. That is not from cellulitis. And I have to remind you, it is possible to have gout and to have a septic joint at the same time. So if your index of suspicion is high, you may still want to give a short course of antibiotics. A patient with such as the one on the left most likely would have a leukocytosis and may even have a fever. The elbow is someone who has a tophus. Again, more pictures of gout. One of the places that we look is in the antihelix in the ear, and apparently since men are not wearing hats as much, we don't see that as often. And this is a picture using the polarizing microscope to make a diagnosis of gout. This is the most definitive test we have. Unfortunately, it's not a polarizing microscope is not available to many people. But even on a regular conventional microscope, you can see on the slide to the right, you see the uric acid crystal piercing a polynuclear cell, and that just says for sure that this is a case of gout. Even with this, you could still have concomitant infection. And the next one I'm going to do is there was recently a multinational group of 78 rheumatologists from Europe, South America, and Australasia convened to make 10 recommendations for the diagnosis and treatment of gout. There's several sets of guidelines that are out there, but I chose this one to review with you. So the first is a diagnosis. Ideally, I mentioned that you would have a microscope to identify the monosodium urate crystals, but otherwise the diagnosis has to be supported by the history. Now men, almost all men will initially have an attack of podagra, which is intense pain that starts in the great toe. But women often will not have the onset of gout in their feet. They may have it in their hands. And it's important to get the history of recurrent self-limited attacks of arthritis which occur more frequently over time and are more difficult to treat. So that's the story, not the classic story, because not everyone is classic. And again, as I've mentioned previously, gout is often misdiagnosed, but this is the very first, the beginning is to get the story correct. Sometimes people say, well, what about the x-rays? Well, x-ray changes take many years to develop abnormalities. So obtaining by the time you see x-ray changes, you're late in the course. And the next, and extremely important, is when you have someone with gout, it's an opportunity to review the comorbidities which are associated with gout. You can see that I put exclamation points after check renal function because this is important for two reasons. Already I mentioned that impairment of renal function can be a cause of the hyperuricemia, but also when treating gout, our medications, we have to be careful with our medications if there's an impairment in renal function. And then we evaluate cardiovascular risk factors because we know that gout is associated with metabolic syndrome, and this is an opportunity to discuss with the patients, do they have hyperlipidemia, is their weight, are they too heavy, and do they have diabetes, smoking. So this is an opportunity not to be missed. Treatment is, we first treat the acute attack. If the attack is less than 24 hours old, and notice I say 24 hours because if you wait longer, it's not going to be helpful. Colchicine 1.2 milligrams followed 1 hour later by 0.6 milligrams is effective, and some people even use this as a diagnostic tool. In the past, we would give the colchicine once an hour until the patient got diarrhea, and we find that this current regimen works just as well and is certainly a lot more humane. Then we have non-steroidals and glucocorticoids, and which the glucocorticoids can be injected, oral, or intramuscular. And the key here is comorbidities. If someone has renal insufficiency, I would be reluctant to give them NSAIDs, and this might be when I would use glucocorticoids, but with glucocorticoids, we only want to use them for the shortest period of time possible. The lifestyle changes are important. I mentioned the comorbidities, and that's what the lifestyle changes are about. Weight loss, increase exercise, stop smoking, alcohol, and especially, as I mentioned previously, beer and high fructose drinks. Even people who are eating a lot of sugared foods, this may help their hyperuricemia, and a lot of people aren't aware of this. Part of the recommendations is not about lead, but because many of you live in parts of the world where lead exposure may be a problem, I would ask about this as well. Once someone has had an attack of gout, the probability that they will have a second attack is very high, but not 100%. After the first attack of gout, we use this opportunity to discuss lifestyle changes, such as weight loss, to stop drinking beer, eliminate sugared drinks, and if possible, eliminate a diuretic. It is recommended to start medication to lower the serum uric acid after 2 to 3 attacks a year, but some patients find that the pain from the attack of gout is so severe that they would like to start sooner. When I start someone in a hyperuricemic agent, I emphasize to them that this is a lifelong therapy, because if they stop it, whatever metabolic defect they had which allowed them to have gout in the first place is still present. The first drug that we think about is allopurinol. Alternatives to allopurinol, and this might be someone who has an allergy to allopurinol, would be probenecid, but probenecid, they must have normal renal function, or febuxostat. Febuxostat is expensive, and there have been allergic hypersensitivity reactions reported with it. And the other is uricase, which dissolves the uric acid, and this is an intravenous drug and should only be used when people have severe tophi and other therapies have failed. And as I mentioned before, we start the drugs at allopurinol or febuxostat at a lower dose so as not to precipitate an attack of gout. Now, the allopurinol hypersensitivity syndrome is something that we all fear, and death can result from this. And it's associated with a worsening of renal impairment, acute hepatocellular injury, and rash. They also can have fever, eosinophilia, and leukocytosis. The hypersensitivity syndrome usually occurs within 30 days, but it has been documented as late as several years after the onset. So we diagnose the gout, we start people on hyperuricemic treatment, but once we've started them, they're still at risk of having an attack of gout until we've cleared the pool. And this is a time where patient information is key, because if the patients do not understand that they could have an attack of gout, and if they have an attack, they are done. They're not going to continue their hyperuricemic therapy. It depends on how much urate is in the pool as to how long it takes to clear it. And if someone has tophi, we can wait for those to disappear, but each individual patient, you have to decide how long to be concerned about potential for acute attacks. Colchicine can be used up to 0.6 milligrams twice daily, or a small dose of an NSAID of glucocorticoids to prevent an attack of gout, but none of these drugs is fail-safe, and again, you need to discuss the patient, especially the prednisone or corticosteroids. try to avoid long-term use if at all possible. Now, as mentioned, renal impairment is a major cause for concern. One of the myths is that allopurinol cannot be used in renal impairment. That's not true. What we found is that if you start at a low dose and titrate up, it can be used safely. If someone has severe renal impairment, I may start as low as 50 milligrams twice a week. And febuxostat can be used in patients who have mild to moderate renal impairment, but with a GFR less than 30 cc's, there's not been research. And we do know that febuxostat has had a few case reports of hypersensitivity. And probenecid should not be used if someone has renal impairment. Today, we treat to target, and this is 36 millimoles per liter or 6 milligrams per deciliter. And if this is done, then the attacks of gout will eventually cease. And the way the target was reached is it's because at this level or below that it is not possible to have supersaturation of the crystals and precipitation. The tophi should be treated medically, and with long-term allopurinol use or febuxostat or other hypouricemic agents, we can usually have them dissolved. If the tophi are severe, you may choose to put your target a little bit lower than what I just stated at 0.3 millimoles per liter or 5 milligrams per deciliter. Surgery is indicated if the tophi are severe, and the uricase is also, I didn't have it on the slide, is also maybe used if the tophi are severe. One of the biggest areas of research right now is what to do about asymptomatic hyperuricemia. It's very interesting that a large number of people who have hyperuricemia do not have gout. And research is going on to see if we should be treating people prophylactically to prevent gouty arthritis, renal disease, and the cardiovascular events are also under research because we don't know if it's a hyperuricemia or the state of inflammation which you have with gout, which contributes to the excess severity of cardiovascular events in some patients with gout. Regardless of whether we're using pharmacologic therapy, which today is not standard of care for hyperuricemia, we would absolutely encourage lifestyle changes. Before I finish this segment, I just want to mention one other thing that I didn't discuss yet is we don't understand what precipitates an attack of gout. I mentioned some people do have asymptomatic hyperuricemia but don't have gout. We think the trauma, and this is interesting because the big toe is certainly a joint that gets traumatized, and fluctuations in serum uric acid can precipitate an attack of gout, maybe even changes in temperature. We don't know. But I hope that with the thought that you have after hearing this talk, that you will make sure that we don't see patients like this and that we don't see any more chronic tophaceous gout, because the price that we pay on both quality of life and days lost from work is really incredible. I have put over here, there's a few sites that you can get to see more pictures. I didn't show any x-rays of gout, but I invite you to see that. And one of the first slide, the first mention there is from the rheumatology.org, which is American College of Rheumatology. And there's even some slides showing uric acid deposits in the neck. You can have it in the back, so you can have a myelopathy from gout. Gout can be extremely, extremely serious. And so I hope that you come away understanding today the story that patients have with gout, but also to improve your approach to people with arthritis in general, how we do the physical examination, pathogenesis, the diagnostic studies, treatment and prevention, and counsel to patients. I've left for you, these are references so that all of you can read more about the discussion today, and I have a second slide of references. So I thank you so much, and I hope all of you have enjoyed this and learned a lot.